So I called my neurosurgeon and said, I need to make an appointment with you. And by the way, I need 280 milligrams worth of OxyContin and 10 Norco if I can't get an appointment until November. And the nurse laughed at me. She said, well, what are you on? And how much are you taking? And with that, a lot opened up in my mind. And I started looking on the internet and realizing, oh my Lord, what has happened to me? And is this why I'm so sick? Is this why I can't work? Is this why I am completely dysfunctional?
I used to say that there was no upper limit to what we could give in opioid therapy, and if a patient felt that they needed more opioid, that it was safe to give it as long as they hurt and as long as they were still experiencing considerable amount of pain, that it would be reasonable to continue to escalate their dose. I would not do that now. I think that we need to look at their function, their mental clarity, and at some point enough is enough, and it's not just more is better.
And so we set about deliberately looking for evidence to support using these high doses, since our clinical impression was that the high doses were counterproductive rather than helpful. And what we were able to show then is that actually that evidence was lacking. And I think that's still true today, that we do not have strong evidence that supports at least the use of very high doses of opiates.
It was a belief by organizations that had made the statement. There was a belief that we developed complete tolerance to the respiratory depression, and that all of these serious adverse effects pharmacologically were protected with slow titration upward. And that led us to believe that, well, if that's the case, then we can continue to escalate the dose and finally get to an analgesic level that would provide pain relief for the patient. That is proven not to be true, partly because of my research.
So as you get to very large dosages, if you continue to want analgesia and you feel that you're not getting adequately treated, so you, as a patient, for example, double the dose. If you double the dose at the low dosages, it won't make much difference in your ability to breathe. If you do that at high dosages, you'll die.
Our clinical observation was that patients on very high doses usually reported severe pain, in other words, pain that hadn't been improved by this treatment, and also that they had a number of other complex issues associated with prolonged use.
By the 6th month, I couldn't work. Strange things, I would fall down, my knees would buckle. By the 7th month, my teeth in the back of my head were falling out, cracking and falling out. I was just sick all the time. I wasn't driving because I did strange things. I left my car out in front of my office one day, running in the middle of the street.
Well, another well-recognized, I think, or certainly becoming well-recognized side effect of opiates or prolonged use of opiates is effects on the neuroendocrine system. So in particular, the pituitary, adrenal, gonadal axis. So clinically, the most important of those is suppression of testosterone in males. But prolonged high-dose opiate treatment also affects fertility in women, and along with testosterone suppression goes secondary effects on energy and libido and drive. So it's certainly one of the things you notice clinically in patients who are on opioids for a long time.
Didn't want to see friends, didn't want to be with friends, didn't want to be with family, didn't want to go anywhere. Lost all reason to go out, lost all need or desire to go out.